Hello, everyone. My name is Lubaina Presswala, and I am a faculty endocrinologist at Northwell Health in Long Island, New York. I have a special interest in diabetes and its impact on cardiovascular disease and renal disease. I would like to thank the organizers of this conference, specifically Dr. Adornetto and Dr. Hasty, for inviting me to speak at the 2021 ACOI Annual Convention. The topic of my presentation is filtering out the potential role of SGLT2 inhibitors for the management of chronic kidney disease. I have nothing to disclose. The objectives of my presentation are to explain the burden of chronic kidney disease, review the pathophysiology of diabetic nephropathy, understand the mechanism of SGLT2 inhibitors in the management of chronic kidney disease, evaluate the clinical trial data for SGLT2 inhibitors and renal outcomes, and finally, to summarize the role of SGLT2 inhibitors in clinical practice. I would like to present two cases commonly seen in our practice and the option to select the most optimal recommendation for their management. Case 1 is a 65-year-old male with type 2 diabetes, hemoglobin A1C of 8%, chronic kidney disease stage 4 with an eGFR of 29, coronary artery disease status post coronary artery bypass graft 5 years ago, congestive heart failure with a reduced ejection fraction of 35%, retinopathy and neuropathy, who presents for management of type 2 diabetes in the office. He's on linagliptin, which is a DPP-4 inhibitor, 5 milligrams once a day, lisinopril 40 milligrams once a day, furosemide 40 milligrams once a day, metoprolol 25 milligrams twice a day, and atorvastatin 40 milligrams once a day. What is your next best recommendation in this case? Stop DPP-4 inhibitor and start SGLT2 inhibitor and possibly reduce furosemide. Stop DPP-4 inhibitor and start GLP-1 agonist and possibly reduce furosemide. Continue DPP-4 inhibitor, start the SGLT2 inhibitor and possibly reduce furosemide, or continue DPP-4 inhibitor, start GLP-1 agonist and possibly reduce furosemide. I will give you 2 seconds to ponder over this and move on to my next case study. Case 2 is a 70-year-old female with type 2 diabetes, A1C of 9%, chronic kidney disease stage 3B, and urinary albumin creatinine ratio 600 milligrams per gram, history of CAD with 2 stents, CVA, who presents for management of uncontrolled type 2 diabetes. She's on glargine insulin 20 units at bedtime and Lispro 8 units before every meal. Self-monitored blood glucose readings range from 180 to 250 with an average of 210. She's on lisinopril 10 milligrams every day, carvedilol 25 milligrams twice a day, and atorvastatin 40 milligrams at bedtime. Her LDL is 68 at the last lab evaluation. What should you suggest at this time? Continue current regimen of basal bolus insulin. Continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on SGLT2 inhibitor. Continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on GLP-1 receptor agonist. And continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on a DPP-4 inhibitor. So I'm going to give you a few more seconds to ponder on this. We're going to return to these cases at the end of my talk today. All right. So let me start by mentioning the prevalence of chronic kidney disease that has increased dramatically in the world for the past 3 decades. Chronic kidney disease significantly contributes to mortality, morbidity, reduced quality of life, and substantial healthcare costs. It is widely recognized as an independent major risk factor of cardiovascular diseases. Chronic kidney disease affects more than 10% of the world population. As per the 2015 to 2018 national survey data reported to the CDC, the horizontal bar graph on the left of my screen represents the percent of US adults aged 18 years or older with chronic kidney disease. Chronic kidney disease is more common in people aged 65 years or older than in people aged 45 to 64 years or 18 to 44 years. CKD is slightly more common in women than in men. It is more common in non-Hispanic Black adults than in non-Hispanic white adults or non-Hispanic Asian adults, and about 14% of Hispanic adults have chronic kidney disease. As noted in the pie chart on the right of my screen, diabetes continues to be the leading cause of end-stage renal disease in the United States, followed by hypertension, glomerulonephritis, and other causes. Thus, it is imperative to reduce worsening of chronic kidney disease and evaluate management options with renal outcomes in mind in the right clinical setting. To understand how chronic kidney disease evolves in patients with diabetes, I would like to backtrack and review the normal physiology of glucose production and utilization in the kidneys. 20 to 25% of the total body's glucose is released by the kidney in the fasting post-absorptive state. Thus, the kidneys are a vital organ in gluconeogenesis, and the main energy source of this is free fatty acids. In the postprandial state, although overall endogenous glucose release decreases, renal gluconeogenesis increases by approximately twofold. The kidney is responsible for 60% of endogenous glucose release. Glucose utilization by the kidneys, mostly done by the renal medulla, after an overnight fast accounts for 10% approximately of glucose utilized by the body. Normally, each day, approximately 180 grams of glucose is filtered by the kidneys. Almost all of this is reabsorbed by means of the sodium glucose cotransporter 2 expressed in the proximal tubules. The diagram on the left of my screen depicts normal renal function with sodium chloride and glucose reabsorption in the proximal convoluted tubule at its physiologic threshold, allowing for normal tubuloglomerular feedback at the macula densa that maintains appropriate efferent and afferent arteriolar tone. Mechanisms underlying glomerular hyperfiltration in diabetes are incompletely understood. However, one plausible mechanism is increased proximal tubular reabsorption via the sodium glucose cotransporter 2, which decreases distal delivery of the solutes, particularly sodium chloride, to the macula densa. The resulting decrease in tubuloglomerular feedback may dilate the afferent arteriole to increase glomerular perfusion, while concurrently high local production of angiotensin-2 at the efferent arteriole produces vasoconstriction. The overall effect is high intraglomerular pressure and glomerular hyperfiltration. As noted in this figure, there's a very complex interplay of metabolic and hemodynamic processes propagating a cascade of events leading to diabetic nephropathy. Diabetic nephropathy can be characterized clinically by hypertension, proteinuria, and ultimately renal impairment. Diabetic nephropathy can be categorized into stages. Hyperfiltration is considered to occur as a result of concurrent renal hypertrophy with intrarenal hemodynamic abnormalities that occur in the diabetic milieu, contributing to glomerular hypertension. The next silent stage may not present with any biochemical or clinical abnormalities. However, it can lead to significant structural changes, including basement membrane thickening and mesangial expansion. With the presence of microalbuminuria or incipient nephropathy, the urinary albumin excretion rate can range from 30 to 300 milligrams over 24 hours, with evidence of advanced glomerular structural changes. Macroalbuminuria or overt nephropathy is characterized by albumin excretion rate greater than 300 milligrams over 24 hours, and the final uremic phase requires the institution of renal replacement therapy. When evaluating long-term risks for patients with chronic kidney disease, it is imperative to look at their glomerular filtration rate and their urinary albumin excretion rate. The chart presented here categorizes the stages of GFR as shown in the rows labeled G1 to G5 with respect to the urinary albumin excretion rate presented in the 3 columns labeled A1 to A3 on the right of the table. Through the combined assessment of GFR and albuminuria status, a patient can be more accurately evaluated as being at low, which is green section, moderately increased, which is the yellow section, high, which is the orange section, or very high risk, which is the red section of worsening kidney function and other complications. And this chart allows for improved decision making with patient and physician mutual decision. The two main studies demonstrating kidney benefit from renin-angiotensin system inhibitors, independent of blood pressure control and diabetes, were the IDNT, published by Lewis et al. In the NEJM in 2001, and the Renal study, published by Brenner et al., also published in the New England Journal of Medicine in 2001, where ARB was compared with placebo, or with placebo and with a calcium channel blocker in a double-blinded manner. Irbesartan in the IDNT study resulted in a 20% relative risk reduction in the primary composite endpoint, which was doubling of serum creatinine, end-stage kidney disease, death from any cause, versus placebo, and a 23% reduction versus amlodipine. While losartan in the Renal study caused a 16% risk reduction in the composite outcome of death, dialysis, and doubling of serum creatinine compared to placebo. These studies demonstrated that renin-angiotensin system inhibitors improve the composite outcome in patients with diabetes and significant albuminuria. As you can see in the adjacent picture, the arterial tone is maintained in a normal glomerulus, while afferent arterial is dilated in diabetes with constriction of the efferent arterial due to the increased glomerular pressure. Following RAS inhibitor therapy, there's vasodilation of the efferent arteriole and effective reduction in the glomerular pressure and proteinuria. However, it is important to note that the afferent arteriole continues to be dilated due to hyperfiltration in diabetes. And this is really where the SGLT2 inhibitors step in. The use of SGLT2 inhibitors reduces reabsorption of sodium and glucose at the proximal convoluted tubule, restoring normal sodium and glucose delivery to the macula densa, restoring the tubulo-glomerular feedback, and in turn decreasing the intraglomerular pressure and glomerular hyperfiltration. There is preservation of intravascular volume, reduction in volume overload, and restoration of the afferent arteriolar tone. Additional benefits of SGLT2 inhibitor on the kidney is reduced stress on the renal tubular cells, improvement in erythropoietin production, improvement in hematocrit concentration, and increased oxygen delivery with potential reduction in pro-inflammatory signals and oxidative stress in other parts of the nephron. Additional cardiac benefits include reduced arterial wall stiffness, reduced blood pressure, weight loss, and less insulin resistance. The increased glucose excretion can result in relative glucose deficiency, lipolysis, and ketone body formation, resulting in the rare side effect of euglycemic diabetic ketoacidosis. There are 4 SGLT2 inhibitors currently on the market, namely canagliflozin, brand name Invokana, dapagliflozin, brand name Farxiga, empagliflozin, brand name Jardiance, and ertugliflozin, brand name Stiglatro. This table represents the clinical utility of SGLT2 inhibitors based on respective GFR categories. Ertugliflozin, which was approved most recently in December of 2017, has the least amount of data at this time. For any GFR less than 30, there's limited benefit of A1C and glucose values. However, based on latest data, has greater utility for cardiovascular, specifically congestive heart failure or renal disease. In clinical practice, anecdotally by endocrinologists and nephrologists, very selective chronic kidney disease patients can be potential candidates for SGLT2 inhibitor initiation for extremely low GFR extending to stage 5, nearing but not on dialysis based on benefit versus risk ratio given their patient's age, overall health status, health literacy about risks, and other factors. And this is based on an individual case-by-case basis. It is important to note that canagliflozin is approved in patients with chronic kidney disease and type 2 diabetes, while dapagliflozin and empagliflozin have been approved for use in severe congestive heart failure and chronic kidney disease in patients with and without diabetes. Following the withdrawal of rosiglitazone from the market in 2007 due to safety concerns of increased cardiovascular risks, the FDA in 2008 mandated evaluation of cardiovascular safety of all antihyperglycemic agents in randomized control trials, designed at least for non-inferiority versus placebo for a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. The randomized control trials for the evaluation of cardiovascular safety among the SGLT2 inhibitors resulted in a myriad of benefits that expanded their clinical indication beyond the diabetes management realm, as shown in this table. There were 4 cardiovascular safety trials done for the SGLT2 inhibitor class of drugs. The DECLARE-TIMI 58 trial evaluated dapagliflozin in more than 17,000 patients for a median follow-up of 4.2 years, and treatment with dapagliflozin did not result in higher or lower rates of MACE, but showed significantly lower rates of cardiovascular death and hospitalizations for heart failure. The CANVAS trial evaluated canagliflozin in more than 10,000 patients for a median follow-up of 3.6 years. The 3-point MACE showed point estimates that suggested benefit. However, the individual components did not reach significance. Nonetheless, there was significantly lower risk of hospitalizations for heart failure, progression of albuminuria, and substantial loss of kidney function in patients treated with canagliflozin and versus placebo. The EMPA-REG trial evaluated empagliflozin in more than 7,000 patients for a median follow-up of 3.1 years. The primary outcome of 3-point MACE was significantly less in the empagliflozin group versus placebo group, meeting superiority for empagliflozin. Additional secondary outcomes, which was primary outcome plus hospitalizations for unstable angina, also met superiority for empagliflozin versus placebo. Empagliflozin resulted in significant cause, death from any cause, and hospitalizations for heart failure. Finally, the VERTIS trial evaluated more than 8,000 patients for a median follow-up of 3.5 years and was published most recently in October 2020. Ortugliflozin was non-inferior to placebo for the 3-point MACE primary outcome. The secondary outcome for hospitalizations or heart failure was not tested statistically. In contrast, no significant benefit of ortugliflozin was observed for the renal composite outcome versus the previous trials that I mentioned. Although these studies were not powered for renal outcomes, the EMPA-REG, which evaluated empagliflozin, was noted for a 38% reduction in incident or worsening nephropathy. The CANVAS program, which looked at canagliflozin, was noted for a 40% reduction in composite of greater than 40% reduction in the eGFR requirement for renal replacement therapy and death from renal cause. And the DECLARE-TIMI 58 trial looking at dapagliflozin was notable for 24% reduction in the composite of greater than 40% reduction in eGFR, new end-stage renal disease, or death from renal or cardiovascular causes. So this risk chart here highlights the baseline severity of chronic kidney disease in patients mentioned in the previous EMPA-REG, CANVAS, and DECLARE-TIMI trials, notable in the early stages of chronic kidney disease, in the stage 2 and A1 green box marked with letters E, C, and D in circles. Based on the outcomes noted in these trials, there was inspiration to initiate trials isolated with renal outcomes in mind. Contrastingly, the CREDENCE, DAPA-CKD, and EMPA kidney trials have included patients with much higher baseline eGFR and urinary albumin excretion rates, as noted by the dotted green, blue, and purple squares on the far right in the background orange and red patient risk category boxes in this chart. For the remainder of my presentation, I will primarily focus on DAPA-CKD and credence trials, focused on primary renal composite outcomes and implications of these results for management of patients with chronic kidney disease. Briefly, DAPA-CKD evaluated more than 4,000 patients on dapagliflozin with and without diabetes, followed for a median of 2.4 years with a mean GFR of 43.1 at baseline for a composite outcome of sustained greater than 50% eGFR decline, end-stage renal disease, renal death, or cardiovascular death. The credence trial was also evaluating more than 4,000 patients on canagliflozin with diabetes, followed for a median of 2.6 years with a mean GFR of 56.2 at baseline for a composite primary outcome of end-stage renal disease, doubling serum creatinine, or death from renal or cardiovascular disease. It is important to note that the credence trial did not include people without diabetes. However, the DAPA-CKD trial included 33% patients without diabetes with a lower mean eGFR at baseline. The EMPA kidney trial, not included here in this table, is a much awaited renal outcome trial and has completed its enrollment of more than 6,000 patients, evaluating patients on empagliflozin versus placebo for primary renal composite outcomes. The study is anticipated to complete in December 2022. DAPA heart failure and EMPEROR reduced trials, as mentioned in this table, were designed with a focus on composite outcomes for cardiovascular death and hospitalizations for heart failure or worsening congestive heart failure. I will defer the discussion of these trials to our cardiology colleagues. So starting out with the credence trial, this is a double-blind, multinational, randomized control trial. It was designed to formally test whether canagliflozin reduced the risk of kidney failure and cardiovascular events in patients with type 2 diabetes and markers of established kidney disease compared to placebo when used in addition to standard of care. 4,401 patients with type 2 diabetes with an A1C in the range of 6.5 to 12% and GFR greater than 30 and less than 90 with an albuminuria ratio and urine albumin creatinine ratio greater than 300 and up to 5,000 milligrams per gram, already treated with a stable dose of ACE inhibitor or ARB, were randomized to either canagliflozin 100 milligrams or matched placebo and followed for a median of 2.62 years. The trial was stopped early after an interim analysis on the recommendation of the Data Safety Monitoring Board Committee based on the significant benefits in the treatment group. The primary outcomes was a composite of end-stage kidney disease defined as dialysis for at least 30 days, kidney transplantation, or an estimated eGFR of less than 15 mL per minute, sustained for at least 30 days, doubling of the serum creatinine level from baseline, sustained for at least 30 days, or death from renal or cardiovascular disease. Patients were fairly well matched at baseline between the treatment and the placebo groups. The mean age was 63, with a greater number of men versus women in both groups. There was a greater number of Caucasian and Asian patients versus Black or African American. Glucose-lowering agents and renal and cardiovascular protective agents were also fairly balanced between the two groups at baseline, as you can see in this table. And similar numbers in both groups were represented in each individual GFR category and albuminuria stage in the study at baseline. So the credence trial has really been a landmark trial, given the significant impact and extremely low numbers needed to treat in order to achieve its outcomes. It is remarkable to know that number needed to treat for renal and cardiovascular outcomes over 2.5 years is as low as 22 in order to achieve the primary composite outcome. The CANVAS trial had previously pointed out a modest difference in A1C values for patients taking canagliflozin versus placebo, with a mean difference of negative 0.25% over the course of the study. It is reasonable to state that there is a modest change in A1C for all SGLT2 inhibitors as a class effect. In terms of outcomes, there was a 30% relative risk reduction in the primary outcome for end-stage renal disease, doubling of serum creatinine, or renal or cardiovascular death. The hazard ratio was 0.70. There was a 34% relative risk reduction for end-stage kidney disease, doubling of serum creatinine, or renal death particularly. There was a 28% relative risk reduction for dialysis, kidney transplantation, or renal death among the two groups. And I would like to take a minute here to explain hazard ratios in order to understand forest plots presented in my talk. Hazard ratio is a measure of an effect of an intervention on an outcome of interest over time. Hazard ratio is reported most commonly in time to event analysis or survival analysis. A hazard ratio of 1 means that there's a lack of association, which really means event rates are the same in both arms. A hazard ratio greater than 1 suggests an increased risk, which also means at any time twice as many patients in the treatment group are having an event proportionally to the comparator group. And a hazard ratio of less than 1 suggests a smaller risk, which means at any time half as many patients in the treatment group are having an event proportionally to the comparator group. As seen in this forest plot, hazard ratios are less than 1, favoring the use of canagliflozin to achieve the primary and secondary outcomes. In this subgroup analysis for the different stages of chronic kidney disease and the range of urinary albumin to creatinine ratio, at baseline, the forest plot highlights a lower hazard ratio of less than 1 in the intervention group, which is the canagliflozin-treated patients, specifically for patients with lower GFR, which was less than 60, and higher urinary albumin to creatinine ratio of greater than 1,000 at baseline for primary composite outcome and renal-specific outcomes as noted here. In terms of all adverse effects, there was a greater risk for the usual urinary tract infections, genitomycotic infections, volume depletion, related hemodynamic changes as well, and rarely DKA. No difference in risk was observed in the Credence trial for fractures and amputations. Whether the increased risk of lower limb amputations in the CANVAS program was due to differing trial populations or protocol or just chance remains unclear. Acute kidney injury was increased in treatment group, however, considered a medically induced acute kidney injury that stabilizes over time, restoring the renal function, restoring the glomerular pressure, and potentially improving chronic kidney disease and albuminuria. So this concept is better explained by this graph representing time in years on the x-axis and GFR on y-axis. An initial GFR dip is anticipated within the first 4 weeks of starting SGLT2 inhibitor. Also noted with RAS inhibitors, where a quick reduction in GFR can happen, followed by a much slower decline in GFR stages over time. This graph nicely highlights the changes in eGFR for a 63-year-old patient with an eGFR of 56 at baseline, with initial dip in eGFR after starting ACE or ARB, as noted by the yellow line in the zoomed-in magnified view, followed by a slower decline in renal function estimated to be 4.6 mLs per minute per year and potential eGFR less than 10 at 10 years when the patient is of 73 years of age. When SGLT2 inhibitor is added on, you can see a crossover of the eGFR slopes within the first year, an initial dip in eGFR, again noted in the magnified view, followed by a much slower decline of 1.85 mLs per minute per year, with a potential eGFR of 10 at 25 years when the patient is of 88 years of age, essentially adding more years to a patient's life for the onset of end-stage renal disease. So in summary, canagliflozin reduced the risk of primary outcome of end-stage renal disease, doubling of serum creatinine or renal or cardiovascular death by 30%, Canagliflozin also reduced the risk of secondary outcomes of end-stage renal disease, doubling of serum creatinine or renal death by 34%. Similar risk reductions were seen for exploratory outcomes, assessing components of the primary outcome, which was 32% lower for end-stage renal disease and 28% lower for dialysis, transplantation, or renal death. Canagliflozin attenuated the slope of chronic eGFR decline by 2.7 mLs per minute per year. So the next trial I would like to present is the DAPA-CKD trial. This was a double-blind, multinational randomized controlled trial. It was designed to formally test whether dapagliflozin reduced the risk of kidney failure and cardiovascular events in patients with and without type 2 diabetes with markers of established kidney disease compared to placebo when used in patients in addition to standard of care. 4,300 patients, including those with and without type 2 diabetes with chronic kidney disease and eGFR of greater than 25 and less than 75, with a urinary albumin creatinine ratio of greater than 200 and less than 5,000, already treated with a stable dose of ACE or ARB, were randomized to either dapagliflozin 10 milligrams or matched placebo and followed for a median of 3.75 years. The primary composite outcome assessed in a time-to-event analysis was the first occurrence of any of the following: a decline of at least 50% in the estimated GFR, which was confirmed by a second serum creatinine measurement after more than 28 days, the onset of end-stage kidney disease, defined as maintenance dialysis for more than 28 days, kidney transplantation, or an estimated eGFR of less than 15, confirmed by a second measurement after 28 days, or death from renal or cardiovascular causes. Secondary outcomes were time to a composite renal endpoint inclusive of more than 50% eGFR decline from baseline, end-stage renal disease defined as an eGFR of less than 15, need for chronic dialysis or renal transplantation, and renal death. Additional secondary outcomes were time to first occurrence of either cardiovascular death or hospitalization for heart failure and time to death from any cause. 681 primary outcome events were needed to detect a 22% lower relative risk in the dapagliflozin group than in the placebo group, with a 90% power. This study was also halted early on the basis of the Data Safety Monitoring Board recommendation when only 408 of the 681 expected outcomes had occurred in view of the overwhelming efficacy. Overall baseline characteristics were fairly similar in patients with type 2 diabetes and those without type 2 diabetes. The mean age was 61 plus or minus 12 years, and 2,906, which is 67.5% patients had type 2 diabetes. There was a greater number of men, predominantly Caucasian, versus women, similar to baseline demographics noted in the Credence trial. A1C was less than 5.6% in patients without diabetes and a mean of 7.8% in patients with type 2 diabetes. The mean eGFR was 43.1 plus or minus 12.4, and the median urinary albumin creatinine ratio was 949. The primary composite outcome occurred in 197 participants, which was 9.2% in the dapagliflozin group, and 312 participants, which was 14.5% in the placebo group, and resulting in a hazard ratio of 0.61, implying a 39% relative risk reduction compared to the expected 22% reduction. The hazard ratio for the kidney composite outcome was 0.56, suggestive of a 44% relative risk reduction with the use of dapagliflozin for the secondary outcomes. The components of all the outcomes highlight the hazard ratio is persistently less than 1 across all components, favoring treatment with dapagliflozin versus placebo. The hazard ratio for the composite of death from cardiovascular causes or hospitalizations for heart failure was 0.71. There were 101 deaths, which was 4.7% from any cause in the dapagliflozin group, and 146, which is 6.8% in the placebo group, for a hazard ratio of 0.69. They both were significant. In a pre-specified analysis of the DAPA-CKD trial evaluating 270 participants with IgA nephropathy and 254 participants with biopsy-confirmed IgA nephropathy, there was a 71% relative risk reduction for the primary and secondary composite endpoints in patients with IgA nephropathy on dapagliflozin. There is potential clinical utility of SGLT2 inhibitors in patients with IgA nephropathy to reduce the risk of chronic kidney disease progression. Finally, to summarize results of the DAPA-CKD trial, it is important to note that 32.5% of patients with CKD did not have diabetes in this trial. 14.5% of patients had an eGFR of less than 30. There was a 29% relative risk reduction for the composite of death from cardiovascular cause or hospitalization for heart failure. In patients with IgA nephropathy, dapagliflozin significantly reduced the risk of chronic kidney disease progression, and post-hoc analysis of dapagliflozin in patients with low magnesium levels also resulted in potential improvement in hypomagnesemia. So what has been the major trial and the Credence trial? The enrollment of a broader spectrum of patients, chronic kidney disease with and without type 2 diabetes, was an important characteristic of the DAPA-CKD study. 32.5% of patients with CKD did not have diabetes, and 14.5% had an eGFR of less than 30. While Credence included patients only with type 2 diabetes and chronic kidney disease with a GFR greater than 30 at baseline. So, do these results apply to all diabetic chronic kidney disease or just proteinuric chronic kidney disease patients? We don't have data for non-proteinuric chronic kidney disease, and perhaps the EMPA-Kidney study will help us inform the use of SGLT2 inhibitors in non-proteinuric chronic kidney disease. We are still waiting on the results of EMPA-Kidney. There is concern, however, for possible cyst growth in patients with polycystic kidney disease, and thus important to avoid SGLT2 inhibitors in this group of patients with polycystic kidney disease. Inflammatory glomerulonephritis were also excluded, in addition to lupus, which was lupus and vasculitis. So no reason to think SGLT2 inhibitors have any role here at this time. One may ask, how low is too low for an eGFR when considering initiating or continuing SGLT2 inhibitors? Published data from clinical trials report empagliflozin initiation down to GFR of 30, which came from the EMPA-REG trial. Remember, we're still waiting on EMPA-Kidney results. Canagliflozin was down to GFR of 30 from the Credence trial as presented earlier, and now dapagliflozin down to 25 from the DAPA-CKD data. Both in Credence and DAPA-CKD, the drugs were continued all the way down to dialysis, and hence there is support for this practice. In clinical practice, however, after a patient-physician discussion of risks and benefits, there can be initiation of SGLT2 inhibitor when the GFR is less than 25, given the potential of adding years to a patient's life before the need of dialysis. This approach is individualized based on patients' risk factors and comorbid medical conditions, and very selectively used in patients given their risk for dehydration and urosepsis. Based on the existing literature, can we say if this is a class effect of SGLT2 inhibitor? So far, we have very remarkable results from the Credence and the DAPA-CKD trials. The EMPA-Kidney trial extends the inclusion criteria further and enrolls patients with and without diabetes with an eGFR greater than 20 up to 45, or eGFR greater than 45 up to 90 with a urinary albumin creatinine ratio greater than 200, with an emphasis on the lower end of eGFR and albuminuria. These results are anticipated in 2022. The much-awaited ongoing EMPA-KIDNEY trial is a multi-center, international, randomized parallel group, double-blinded, placebo-controlled trial of empagliflozin once a day to assess cardiorenal outcomes in patients with chronic kidney disease. This trial is now closed to recruitment and will include about 77,000 patients with and without type 2 diabetes, eGFR greater than 25 and less than 45, or GFR greater than 45 and less than 90 with an albumin to creatinine ratio greater than 200, as I mentioned earlier. Empagliflozin 10 milligrams or 25 milligram dose will be added on baseline ACE inhibitor or ARB therapy and matched with placebo. Patients will be followed for a median of 3.1 years. The composite primary outcome is time to first occurrence of kidney disease progression defined as end-stage kidney disease, a sustained decline in eGFR of less than 10, renal death, or a sustained decline of greater than 40% in eGFR from randomization, and secondarily, cardiovascular death. Additional SGLT2 inhibitor benefits include modest reductions in hemoglobin A1C levels, reduction in blood pressure and weight. SGLT2 inhibitors have a role in treating IgA nephropathy as seen by the use of dapagliflozin. Hypomagnesemia has also known to have improved with SGLT2 inhibitor use based on post-hoc analysis data. And finally, studies indicate SGLT2 inhibitors can potentially help with sodium retention in patients with SIADH. As an endocrinologist with a focus on cardiovascular health and renal health, I would like to take a brief minute for a word on injectable GLP-1 receptor agonist and with the only one oral formulation for semaglutide as an exception. There have been several trials on GLP-1 receptor agonist, and the greatest benefit observed for these agents is for primary composite cardiovascular outcomes in patients with significant pre-existing cardiovascular disease at baseline. The columns in this table presents the large number of patients in each trial, followed over time for 1.3 to 5.4 years on average, with significantly high percent pre-existing cardiovascular diseases at baseline, with the exception for the Rewind trial, where the cardiovascular disease at baseline was only 31%. Patients also had baseline A1C higher than notable in the SGLT2 inhibitor trials and a baseline BMI of greater than 30 in all the trials. The primary composite outcomes were slightly different between the trials. However, all trials focused on one or more outcomes inclusive of death from any cause, death from cardiovascular cause, non-fatal MI, non-fatal stroke, and unstable angina. It is important to keep in mind that these trials were not dedicated for heart failure outcomes. Additionally, there was a significant reduction in weight and hemoglobin A1C in GLP-1 receptor trials, versus only modest reduction for A1C in the SGLT2 inhibitor trials. Trials that had a p-value of less than 0.05 for primary composite cardiovascular outcomes were the LEADER trial, which is liraglutide, brand name Victoza, SUSTAIN 6 trial for semaglutide, brand name Ozempic, and Rewind trial, which is dulaglutide, brand name Trulicity. Among these trials, Rewind was particularly helpful for patients with less percent cardiovascular disease at baseline, and given significant results, may significantly help those patients at high risk for cardiovascular disease, an aspect that leans towards primary prevention a little. Dulaglutide or Trulicity is also the most user-friendly injectable pen device for patients to use at home only once a week. This complex Cox analysis on primary and secondary outcomes after stratification according to pre-existing cardiovascular disease helps evaluate the role of GLP-1 receptor agonist or SGLT2 inhibitors. It is imperative to review their history of prior MI, stroke, or revascularization to determine if GLP-1 receptor agonist may be a suitable agent for that particular patient. This is a link to a program that serves as a tool for physicians to select from among the GLP-1 receptor agonist category or the SGLT2 inhibitor category of medications for their patients based on individual baseline comorbid medical diagnosis. It's called the Match It program. Here is an example of the results among 1,000 people for a period of 5 years when selected categories of adults with type 2 diabetes and with cardiovascular disease and chronic kidney disease at baseline. When selecting SGLT2 inhibitors in clinical practice, it can be used as an adjunct to diet and exercise and/or metformin and/or other glucose-lowering agents for type 2 diabetes management. If diabetes is well controlled, consider dose reduction of other diabetes agents. If diabetes is uncontrolled, consider SGLT2 inhibitors as add-on therapy. The intravascular volume depletion may result in reduced blood pressure or dizziness, so consider dose reduction of other antihypertensives or diuretic agents. A drop in eGFR is expected and should stabilize over 3 to 4 weeks. Can consider reassessing renal function if SGLT2 inhibitors are safe and effective for as low as GFR 20, and though caution is advised for GFR between 20 and 30. Continue SGLT2 inhibitor until the onset of dialysis, and be mindful of UTI or genitomycotic infections and rare risk of euglycemic DKA in clinical practice. All right, so going back to our case studies, I will present the case study 1 and provide you the answers. And I hope at this time you have learned enough from my presentation to get the answers yourself. So a 65-year-old male with type 2 diabetes, A1C of 8% with chronic kidney disease stage 4, eGFR of 29, coronary artery disease, status post bypass surgery 5 years ago, congestive heart failure with a reduced EF of 35%, retinopathy and neuropathy, presents for management of type 2 diabetes. He's on linagliptin, which is a DPP-4 inhibitor, 5 milligrams once a day, lisinopril 40 milligrams once a day, furosemide 40 milligrams once a day, metoprolol 25 milligrams BID, and atorvastatin 40 milligrams once a day. What is your next best recommendation? Stop the DPP-4 inhibitor and start SGLT2 inhibitor and possibly reduce furosemide. Stop DPP-4 inhibitor and start GLP-1 receptor agonist and possibly reduce furosemide. Continue the DPP-4 inhibitor, start the SGLT2 inhibitor, and possibly reduce furosemide, or continue DPP-4 inhibitor, start the GLP-1 receptor agonist, and possibly reduce furosemide. So what do you think? I'll give you a couple hints. CKD stage 4, GFR 29, CHF with an EF of 35%, A1C of 8 for a 65-year-old male. All right. So you would want to continue the DPP-4 inhibitor because the A1C is not at goal. You want to start additional SGLT2 inhibitor in this case because the patient has a reduced ejection fraction of 35% and congestive heart failure at baseline and a lower GFR to begin with, which is 29 mLs per minute. And given the adverse effects of intravascular volume depletion and risk for dehydration, you would want to consider possibly reducing the furosemide. Additionally, you can also switch the DPP-4 inhibitor for a GLP-1 agonist agent in the future for cardiovascular benefit for this patient. Since we usually prefer not to start two new medications at one time, we can keep the switching part for later. Okay, so case study 2. This is a 70-year-old female with type 2 diabetes, A1C of 9%, with chronic kidney disease stage 3B, and urinary albumin creatinine ratio of 600 milligrams per gram, history of CAD with 2 stents, history of stroke, who presents for management of uncontrolled type 2 diabetes. She's on glargine insulin 20 units at bedtime and Lispro 8 units 3 times a day before each meal. Self-monitored blood glucose readings range from 180 to 250, with an average blood glucose of 210. She's on lisinopril 10 once a day, carvedilol 25 milligrams twice a day, and atorvastatin 40 milligrams at bedtime. LDL was 68 at the last lab evaluation. What should you suggest at this time? Continue current regimen of basal bolus insulin, continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on SGLT2 inhibitor. Continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on GLP-1 receptor agonist. Or continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on a DPP-4 inhibitor. So I'm going to give you a couple more seconds to look that over. Any ideas? Here are some hints. Type 2 diabetes with an A1C of 9%, not at goal. CKD stage 3B, coronary artery disease, specific history of a stroke in the past, and her blood glucoses at home are uncontrolled. All right, so I hope you guessed it right. It is continue current regimen of basal bolus insulin, start continuous glucose monitoring, and add on a GLP-1 agonist in this case, given the history of stroke, as well as the coronary artery disease. And you want to add on therapy primarily because the A1C is uncontrolled and her finger sticks are uncontrolled as well. So you want to continue the insulin as well. And being 70 years of age, it may be a good idea to put her on continuous glucose monitoring, given chronic kidney disease stage 3B, to monitor for hypoglycemia at home as well. All right. So in conclusion, SGLT2 inhibitors should be considered in all patients with type 2 diabetes and chronic kidney disease. SGLT2 inhibitors are approved for use in patients without diabetes, with chronic kidney disease and proteinuria. SGLT2 inhibitors may be used in diuretic-resistant cardiorenal syndrome. SGLT2 inhibitors can be considered for refractory SIADH, hypomagnesemia, and possible prevention of kidney stones. These are my references. I would like to thank my esteemed colleagues that have significantly contributed their time and resources in making of this presentation. And I would like to thank you for your attention, and I would be happy to answer any questions from the audience. I have listed my email and my cell phone number in case you want to reach out to me at a later time. Thank you.